I'm Mara Antonoff. I'm a thoracic surgeon at MD Anderson in Houston.
Hi, I'm Jonathan Spicer, a thoracic surgeon in McGill in Montreal, Canada.
Well, I'm really happy to have you here, Dr. Spicer, so we can talk a little bit about your late-breaking abstract that you presented here yesterday at the STS related to the surgical outcomes from Keynote 671. Can you just remind us what had been previously presented related to that study and kind of what the methods and general findings that we knew about prior to your late-breaking abstract yesterday?
Sure. So Keynote 671 is a randomized study comparing perioperative pembrolizumab with chemotherapy versus chemotherapy alone, placebo, for resectable stage 2A to 3B non-small cell lung cancer. And we have the primary endpoint results now. So EFS was statistically positive. That was presented by Dr. Wakely at ASCO last year, and then we presented at ESMO the overall survival results. So it is significant because it's the first study to show overall survival in the context of neoadjuvant chemoimmunotherapy. So that led to the FDA providing a Category 1 recommendation in the NCCN guidelines, and so it's available for surgeons and oncologists here in the U.S.
Terrific. And so then yesterday we found out about the surgical outcomes, and can you share this a little bit about what you presented and whether it was what you expected to find?
Sure. Well, not all, but some of the data that we presented was already sort of in the New England manuscript, so I encourage people to go through there. Sometimes it's unfortunate as a surgeon you have to dig through the supplemental to see a lot of the data that's relevant to us, but it's worth the effort. But what we presented that was really new yesterday was some of the outcomes regarding choice of procedure. So there was a little bit higher rates of lobectomy in the pembro arm. There are fewer patients who went to the OR and were found to be unresectable in the OR, so about a third fewer patients who were unresectable at surgery. Higher R0 rates, so in the low 90s versus the low 80s with chemo. And a few interesting findings around perioperative mortality, so 30 and 90-day mortality outcomes. So the 90-day mortality for the whole cohort in the pembro arm was 4%, and for the chemo arm with placebo was 2%. So a difference there, but if you look at 4%, how it benchmarks to, say, the GTSD data that was presented by Dr. Sater afterwards, it's well within what's expected from that. So I think the real world data will be important there to see, is there something real here? And the other important data that we showed was the mortality data for the pneumonectomy group, where we saw quite a few more mortalities in the pneumonectomy group with pembro than with chemo alone. And then the last bit was looking at, they're not pre-planned subgroups, they're post-randomization subgroups. So it was very interesting to see is that patients who actually had a surgery had much higher benefit, whereas those who did not, which is a little bit new compared to what we had seen with Checkmate 816, and the importance of getting an R0 resection. So the hazard ratio was far more favorable to the pembro group when an R0 resection was achieved than when it was R+.
Not super surprising.
Well, not really, but surprising compared to what we had seen in 816, where that wasn't so much the case, where the hazard ratios are still favorable in the incompletely resected.
And it's actually maybe even a little bit bizarre considering that 816 is only neoadjuvant. So you're right. You would think that leaving disease behind if you're going to get adjuvant would maybe not matter quite as much, but different drugs and
also small subgroups, so prone to misinterpretation and error. So I think the advantage of 671 is a very large study. There's 797 patients who are randomized, so the subgroups are a little bit more robust when it comes to those things.
And what do you think these findings mean when we look at them in the context of the other trials that we've had of late and are still having ongoing outcomes data presented in the area of perioperative immunotherapy for resectable disease?
Yeah, there's an abundance of data now, right? We have like almost too many options.
Right.
And so one of the questions that comes up all the time is how do you choose? And I think the only real choice that we have right now is pure neoadjuvant, so the Checkmate 816 approach versus the perioperative approach, which for now is limited to the pembro option, but without a doubt will be opening up, at least in the US, to other options as well. There's no good answer to the question. If you look at the EFS at 2 years, it's not too far off one from the other. So from a global standpoint, you wonder where's the benefit of the adjuvant component. But the perioperative regimen with Pembro has overall survival. The Checkmate 816 has not yet hit on overall survival. Is that an issue of power, or is it just that it's not going to hit? We don't know yet. So I think that's why it has that high level of evidence with the perioperative. The risk is over-treating some people and exposing them to IO-related complications who might not need that.
As well as the cost and the inconvenience, the social challenges of it. And it is also unfortunate that most of our trials with perioperative seem to have 4 cycles of neoadjuvant, whereas 816 had 3, and that's also a difference in cost, difference in social challenges and everything else. So
well, and with no clear signal of making a difference in terms of pathological response, right? So the pathological response rates from the perioperative 4-cycle regimens is no better than what we've seen with 816.
So obviously we've answered a ton of great questions in recent years with these trials, but there are a lot of questions that remain.
Absolutely.
Yeah.
So I think the big ones that are still out there, a lot of surgeons still believe in upfront surgery for stage 2. And I think there's reasonable justification to have equipoise with regards to that. I think less so for stage 3. It's really hard to justify going straight to the OR for a stage 3 patient unless there's some mitigating scenario. But so stage 2 patients are underrepresented and probably need more data, and maybe there is room for a randomized trial comparing neoadjuvant to upfront. I favor neoadjuvant, but it's mostly just based on my bias in that regard. The other obvious unanswered question is neoadjuvant versus perioperative. And so some cooperative groups are looking at that. I think the challenge there is that there are other studies that are escalating the regimens in the neoadjuvant setting. So by the time we get results of that comparison, we might have a whole new preoperative regimen that we'll be considering. So,
it's an exciting time.
It is,
Lots more to come. Well, thank you so much for chatting with us today.
Thanks for having me.